Hello everyone, how are you feeling?
Good.
Great, nice. It's getting late in the day, so I will try to keep it pretty chill and not go into complexity too much. I don't think my brain could handle that anyway. So my name is Carl Enholm, and I have a Master of Science in Psychology. And together with Alexandra over here, I work on a ketamine treatment in Skövde in Sweden. I actually pointed it out here on a map since you probably don't know where it is. It's right like in between our two big lakes in Sweden. So that's where we're at. And today I'm going to talk about ketamine, which is a medicine with diverse application in modern healthcare. It's been used since the 60s, mainly for anesthetic purposes, but also for like painkilling purposes and stuff like that. But now in the recent 20 years, you've seen it being increasingly administered to patients with treatment-resistant depression. And this medicine is both being used as in its original form, so racemic, which is when you have the both sort of chemical mirrorings in the chemical, or you have this Spravato, which is a nasal spray with only one of these mirrorings of the chemical. So Spravato is an approved medicine since like the 2019, 2017, depending on where you look. But the racemic one is not approved as a depression treatment up until very recently, actually, in Norway. But Spravato is very expensive. It costs a lot, while racemic ketamine costs like €1.5 per dose. So many doctors actually go for the racemic one because it's so cheap, right? And we have a variety of designs on ketamine treatment, and this you can divide them into biomedical and psychedelic ketamine treatments. And I mean, you cannot really divide them clearly into these categories, but these are like the polarities. And it's an unclear role right now about like the subjective effects of ketamine. Do these subjective experiences that patients have, do they matter for treatment outcome? So I will focus on these two today, mostly. So this is the current state in Sweden. 17 out of the 21 regions treat with ketamine or has treated with ketamine for depression. And you also see these brackets, like the numbers with the brackets in, and that is like how many treatments the patient has gone through before getting ketamine treatment. Or potentially getting a ketamine treatment. So it's very like widespread now in Sweden. And it's only a few of these that use like ketamine regularly in depression treatment, but a lot of the regions haven't used it, at least at some time. So this approach is to ketamine treatment then. So this biomedical approach focuses on ketamine's pharmacological and neural effects as the primary mechanism of actions, where subjective effects are seen as side effects to the treatment, something that we want to be avoiding. And proposed mechanisms increased synaptogenesis, glutamate modulation, enhanced metaplasticity, activation of 5-HT serotonin 1B receptor, and so on. So it's this like neurobiological explanation models. And then we have the psychedelic approach, where the subjective experience are seen as central to the therapeutic effect, where ketamine enabled therapeutic experiences of insights, emotional expression, and cognitive restructuring. And then that this experience can be then integrated into behavioral change, and then that is the mechanism of how this treatment works. And this, of course, leads to differences in how you would design the ketamine treatment. So, for instance, in the biomedical approach, the experience want to be minimized or managed through distraction and, if needed, sedatives. So you get these dissociative side effects, right, that you want to minimize because those are not pleasant. And you have a standardized dose, usually 0.5 milligrams per kilogram over 40 minutes. Medical staffs are nearby and check in on the patient. And the goal is symptom reduction. And in the psychedelic approach, then, you have the more experiential consideration. You have set and setting that probably a lot of you people in here are familiar with. You have a flexible dosing where it's more about maybe getting the patient to a certain experience or to get experiential content rather than, having a standardized dose. And then you have a dedicated sitter or therapist that is present throughout. And the goal is like psychological insight and transformation, initiating sort of these psychological processes, right? Okay, so again, like this is really like the polarities, and we have a lot of like in between here, right? And one of this, the question is, how can we integrate these perspectives, right? And one of these attempts has been the Montreal model, which is an integrative model to ketamine treatment. It's been developed in Montreal, go figure. And it's a pretty chaotic like flowchart, but I just want to show it because I think it's so beautiful. So we can see here that it's divided into 4 like sections here. And what it is really, it's like it's acknowledging that you have this sort of neuroplastic, metaplastic effects that you can use to sort of form new behaviors and lifestyle changes. And this is integrated with a behavioral activation where you're like really zooming into the patient's lifestyle and looking at, okay, how can we help this patient to activate themselves in certain aspects? And this is very good, I think, for this patient population. With treatment-resistant depressed patients, you're usually seeing a very inactive pattern. If you've been depressed for over a decade, you're usually very inactive, and you need to become activated. So you're using the whole treatment really to do this behavioral activation. You start with it even beforehand, and then you have this rolling preparation and integration where you talk about the expectations for the infusions, and then you have facilitated treatment sessions where you have music, mindfulness, eye shades. And then afterwards, you also talk about the experiential content that might have come up during the ketamine infusion. Yeah, sorry for this chaotic flowcharts. So this is me. I didn't get treated with ketamine, unfortunately, but this is how it looks. And drawing from the Montreal model, we have implemented this, but we had to do some adaptation due to lack of resources. So we still have a clinical environment. We don't have this more cozy, like living room standard that you're seeing in Montreal. And we don't have any concomitant psychotherapy with the patients. I realized I forgot to mention both of these aspects as a part of the model, but here I did at least. Cool. So now we come to like our research question that we've had down in Skövde. And this is, do the subjective experiences in ketamine treatment matter for tolerability and efficacy? So this is a pretty interesting study. It's a meta-correlation of the effects of ketamine and psilocybin-induced subjective effects on therapeutic outcome. And in this one, they're seeing like an explained variance of 0.24, so almost a strong sort of link between the subjective effects and outcome with psilocybin. But with ketamine, they're seeing only like 5 to 10%. So one of the like conclusion that they draw from this is that, well, maybe like it doesn't matter as much in ketamine treatment. It's more of a strictly biological effect that's going on. But what they fail to like place focus on, they discussed this just a short sentence, but if you look at what type of questionnaires that is being administered in the psilocybin and the ketamine research respectively, you're actually seeing that it's these pathological scales in ketamine research. So CADS, a dissociative scale, and brief psychiatric rating scale is being most commonly used. But in psilocybin research, you're seeing this mystical experience questionnaire, emotional breakthrough inventory, psychological insight scale, these more positively balanced questionnaires, right? So when you compare them, like, of course, you're going to have like differences because of that, right? So we figured that we should, right, I just want to show, these are also studies that have used this more psilocybin questionnaire, or this questionnaire is more commonly used in psilocybin research, but with ketamine, showing some really interesting results, positive correlations with these experiences and outcome. But we wanted to further look into like how this questionnaire is commonly used in psilocybin research upholds in ketamine treatment. So we use these experiential questionnaires: psychedelic experience questionnaire, psychological insight scale, emotional breakthrough inventory, psychedelic music experience questionnaire, the awe experience scale, and challenging experience questionnaire. We also use MADRS self-report for the depression measures. And then we also ask the participant to rate their perceived importance of these different interventions that we were applying. So the music, the mindfulness, the eye shades. And then also we did an interview on their subjective experiences and these adjunct interventions to get their thoughts on it. Right. Oh, this became really small. I'm sorry. Do you see it? I have to squint your eyes a little bit. So the primary and secondary research question was, how do subjective experiences predict changes in depressive symptoms from baseline to 1 week and 8 weeks after treatment? So this more short-term and long-term effects. And then we also had some exploratory measures where we looked at like the usage patterns of this music, eye shades, mindfulness, because those are optionals. The patient can either like use them or they can decide not to. And also we asked, as I said, we asked also about these interventions and like trying to get the patient's thoughts on their importance and like how. If they're improving the treatment in certain ways. Bless you. All right, so this is the flow chart of the treatment. We like did the most of the data collection 1 week afterwards, and this is like we're trying to balance it, where it's just like. We want to administer it after each treatment session, right? But it's like 100 questions in total, and these are severely depressed patients. And, for them to every time like have to sit down and answer these questionnaires, I think would be not really ethical. So we limited the data collection to one time, but then like we didn't want to put it like directly after the last infusion either, because then it's just like. You have so many recency effects probably from the last infusion. So we balanced the sort of recency effect and the recall bias by putting it 1 week after the last infusion. And then this one are matrices, the green ones. Okay, so we have some preliminary results here. This data has never been shown before. So I hope you feel honored. It's very preliminary. It's like 10 patients. From 59 infusions, so please don't go too hard on this data and like make wild conclusions. I will try not to. I have a hard time doing that. So this is the MADRS scores, where we're seeing a sort of decline here up until the 1 week post, and it goes up a little bit the 8 week post, and we're not having any sort of we don't have the statistical power to see to actually see like statistically significant changes here, but we see trends in the data. And what's interesting is that we have a pretty big variability. So like some patients respond really well to the treatment, like fully remit, almost like score 0 on the MADRS, while others stay the same or even go up a little bit. So that's an important thing that isn't really shown in this graph. So what about like these experiences? What are the people telling about them? So I've interviewed all these patients, and it's really interesting to see like how different it is for these patients. So like one patient told me that, yeah, it was like I saw my thoughts and my self-destructive thoughts and how they were traveling like towards this point in the middle of my forehead. And I could finally see how cruel I am towards myself. And it made me realize that I don't have to do this. I don't have to be cruel. And another patient, he said, yeah, I felt relaxed. but that's it. It's just like, so, you know, it's huge difference. And if we look at these correlations between the scales and outcome, so this is the score on the questionnaires down here, and then on the y-axis, the percentage MADRS change. You're seeing a pretty big correlation here between the psychological insight score and MADRS change, where the correlation is at 0.64. And you actually have a statistical significance there with only 10 patients. This is the R score, where you actually don't see any sort of correlation in the sample. And this is just an overview. R squared on the y-axis, and then this one. And I really wanted to put this one going downwards because it's a negative correlation with outcome, challenging experiences. Yeah, I don't want to put too much emphasis on the data since we have to gather more data before, but never been shown before. To be announced with the 8-week post. So yeah, the usage for this one is so small as well. My God, what happened? It must be Samuli has been edited in the slides. So we had a requirement of behavioral activation and psychological support because we believe behavioral activation is such a crucial part of the treatment. We begin with that even like 2 weeks prior or 1 week prior to the treatment. And psychological support, we always have like a nurse or a therapist nearby, or a doctor. So like a clinician is always nearby or with the patient throughout the infusion. So that's required in that sense. But the optional interventions then is pretty interesting, like that we have mindfulness on 44 of the 59 infusions, and music on all the infusions actually. And then eye shades on 36 of the 59 infusions. But I want to say, even those infusions where you didn't see an eye shade usage, like almost all the patients were closing their eyes and emphasizing the importance of like closing your eyes and having this inward focus. And if you look at the ratings of perceived importance here, you're seeing that psychological support was the winner, if you can say so, at 9.3. And they emphasized like how good it felt to have someone who really cared, who sat there besides them. And it felt like they were an anchor to like reality and like providing a safe and sort of calm presence. Then with music up there in the second place, music had a guiding role, eliciting emotions, memories. Eye shades was actually rated pretty high, and this was interesting. Like even those who didn't use the eye shades, some of them put a 10 up there because they were like, yeah, I mean, I have my eyes closed all the time, and I think that was really important. So they put a 10 there either way. Mindfulness was well received by some, while some just thought it was totally useless. And that, no, I tried that before. That's nothing for me. So we're like, at least I'm wondering, like maybe you should rephrase it. Don't call it mindfulness, because like to promote the sort of relaxation and let's say openness to experience through just letting sensation come and perceive them. I think that is could be helpful for most patients, but we call it mindfulness for now. And the behavioral activation was pretty constant at this like 5 up until 7, where it's like, yeah, I think that it was important, but yeah, didn't really stood out as something that the patient perceived as super important. All right, so we have some limitations with this research. Oh, it's so small. So the data collection 1 week, I talked about this already. And the external validity, is the data bound to this context? We have to ask this question, like maybe we cannot like say that this experiential data and what we're hearing from our patient actually applies to ketamine treatment generally. Maybe it just applies if you have this sort of more psychedelic approach where you have this experiential consideration and sort of different adjuncts to the treatment. And what does this scores really say about the experiences in a wider context? So, like, having these experiences is one thing. But then to actually talk about them, to deepen them, to make sense out of them, that's another aspect that might be just as important as actually having the experiences. Integrating them into something that is meaningful and to, actually look at them and expand on them together with someone who's curious and like asks about them. So back to the Montreal model, I think that this model actually does that. If you apply the Montreal model in the ketamine treatment, then you're facilitating the patients not only having this more deepening of experiences and meaning making around them, but also like going directly at these lifestyle changes and like really showing the patient that you care. This one is really small as well, no surprise. So potentially making ketamine treatment more safe and effective through utilizing change potentiality and experiential consideration. It's Montreal model. The model is adaptable, shape, and relatively easy to implement. As you've seen, in Skövde, we adapted it a little bit according to our resources, but it still works out pretty good, we think. And then this is also like an interesting thing that it might help building out the infrastructure for psychedelic treatments. If psilocybin and MDMA gets approved in a couple of years, then the bottleneck is going to be specially trained clinicians and clinicians who have know-how into how to treat patients in an altered state of consciousness. So already now, if we're doing that with ketamine, then we might be able to prepare the healthcare system for these treatments. And this is what's happening now in Norway. This is actually from Borealis conference last week in Stockholm. Lowen, there he got a prize, the Pioneer Award, for leading the sort of the policy changes around ketamine, where they got generic ketamine approved as a treatment method for depression. So it's already happening there, and they're rolling it out with the Montreal model in Norway. And I just want to mention this before, I know my time is probably up, but we're starting a framing trial, the CAT-SET trial. Oh, that's really small as well. So this one we're going to look at framing. We're going to have a biomedical framing in one arm and a psychedelic framing in the other. So this is just to see if it's actually is a difference in efficacy and tolerability between these approaches. And this can possibly help us help illuminate how we can optimize this treatment for patients. So please, if you're interested in collaborating on this or like helping out with the design, have some ideas, then talk to either me or Alexandra that's over there. Would be super nice. Cool. Thank you to these persons.
Thank you so much, and congratulations on the pioneering work, as there is so little like data published on or even done on this, like the extra pharmacological methods. And so we are starting Montreal-like model in Finland in a private setting. So very curious about then those, well, I have many questions, but maybe like the non-responders. I guess you can't say if it's really more than in the biomedical setting because of the like 10 patients, but did you have any like characteristics of those patients, maybe comorbidities or anything else that might have predicted their non-respondence?
It's hard for me to say anything about the non-responders. I think it's better. I think it's more easier to see patterns in the responders. So the responders usually have like personally meaningful experiences. They're usually very prone to to like work on these lifestyle changes very early in the process, and they're usually like engaged in the treatment process in another way. They're not the passive receivers of the treatment, but they're actually active in the treatment. So maybe passivity in the treatment program is a sort of something that you can say. But yeah, as you're saying, it's only 10 patients in the study. We've treated, I think, 17 in total down in Skövde now as we speak. So yeah.
Thank you very much.
Yeah. Let's talk later. Huh?
Other questions? Maybe the first.
Thank you. First of all, the text was small, but the ideas were big, so you're all good. My question is about, there's a lot of emphasis on like set and setting, and I'm especially interested though in like intention and integration, and what goes, especially now you said the non-responders weren't kind of engaged. What kind of intention setting goes into this process, and what kind of integration goes into this process?
Yeah, it's a very good question. So, I mean, I think that that's very individual. We don't have any rules that you have to have an intention, for instance, but we're trying to talk about, with the patients, we're trying to talk about, okay, how would your life look like if you weren't depressed? How would you want to live your life? And sort of getting them into these thoughts or thinking about like, okay, how do I want to live my life, and how can I do that? How can I work towards that? What kind of behavioral changes do I have to go through to get there? So I suppose like we're not setting, we don't have a rule that you have to set an intention, but we're trying to help the patient form that throughout the treatment. And you were also asking about the integration. Yeah, so I think that from my limited experience, I think that it's just important to leave room for that. But I'm pretty like, I feel sometimes very confused like in treatment when it comes to integration, like because I try to have this very non-directive approach where I just follow the patient's process. But in a way, I've seen some patients like fall into this more ruminative patterns that I fear like isn't serving them. So then I feel it's hard. It's kind of hard to navigate that. But I have a very limited experience in treating with ketamine in this regard. So hopefully I will get better at it. Do you have any ideas on the integration process?
Thank you for giving a question back. It's a very interesting topic, and I think where you're right is that it's a very personal experience, and I think it's a very somatic experience as well. So I'd think about somatic methods, embodied methods, artistic methods. Those are maybe the ones that I'd be turning to when it comes to integration practices. And maybe the very important thing that you also noted is that somebody is there and available. The part that just someone is available when you need them. I'd say that's the biggest thing about integration.
100%. I think that's really the most important part, that you're there and that you're curious, around the experience.
And for a long time, because what I think that a lot of the research on psychedelics, the problem is that we look at like week 1 and week 7, but what about a year from now or 2 years from now? What's happening with these people going through these experiences? So
yeah, definitely. And we do these checkups at 6 months, at 12 months. So I mean, the reason why we're not including it in the research is to avoid getting too many dropouts. But yeah, I think that you're right.
But even with the like 6 months, if there's nobody there for you in between, that's also can be quite.
I totally agree. But like we have a limited amount of resources, and in an ideal world, I could be there every day.
I'm sure they'd love you to be there every day.
Thank you.
You seem like a lovely person.
Stop it. All right.
Thank you so much.
Thank you, everyone.